So dear colleagues, ladies and gentlemen, good afternoon to everyone. I welcome you all to the 15th virtual meeting of Medanta Echo and Cardiology today and tomorrow. This is our Best of Cardiology series, and this is a special session with South Asian Society of Atherosclerosis and Thrombosis, which I preside, and the topics are very noteworthy actually, and quite topical because atherosclerosis imaging is coming up in a very, very big way. I'm honored to have, as the meeting chairman, Dr. Rajeev Agarwal from Meerut, who will just join us. He's busy in us. Who is a mature young cardiologist from Meerut, a very prominent figure in the field of lipidology and atherosclerosis. He has numerous scientific contributions and awards to his credit and is a source of inspiration to budding cardiologists of our country. And I may say, and I may add, that vascular biology is his passion. With these few words, ladies and gentlemen, I hand over the baton to you, Dr. Rajeev, for further interaction with our group. Ladies and gentlemen, Dr. Rajeev and Dr. Manish Bansal, sir.
Yes.
Dr. Rajeev is there.
Yeah, sir. Good morning, good afternoon. Good afternoon, everybody.
Welcome.
I think today is a very important day for all the clinical cardiologists and intervention cardiologists because we are going to speak on a disease and a menace of the 21st century. Atherosclerosis like tuberculosis, cholera, malaria, which were the diseases of the 20th century. I think the same importance or nuisance is enjoyed by atherosclerosis today. There is a famous saying, atherosclerosis never sleeps. That means it relentlessly progresses. For the first time in the history, we have unique opportunity to tame the disease by lipid modification. From regression to elimination, and it is common sense that if we hit the disease young, that means preclinical atherosclerosis, naturally, we have low investment and high returns. So it's a very challenging area. Like pre-diabetes, we have a concept of pre-atherosclerosis, preclinical atherosclerosis, where we can tame the disease early, as you say, nip in the bud. Dr. Kasliwal enjoys unique position among the cardiologist fraternity because I enjoy tremendous influence of him from my building years, and he influenced my interest in preventive atherosclerosis. So, ladies and gentlemen, I'll present before you Dr. Ravi. He has got a distinguished cardiology career spanning for more than 4 decades. And I always recall he interviewed me for a senior registrar when Ascot Heart Institute was coming up, and I was working in a Holy Family Hospital. He mentors Diplomate National Board of Cardiology Fellows and also fellowship program in clinical preventive and non-invasive cardiology. He also mentors physicians from India and abroad in the field of echocardiography, preventive cardiology. Amongst the more than 275 national international awards, he also received the prestigious B.C. Roy National Award for the 2004 by Bharat Ratna Dr. APJ Abul Kalam, the then President of India, and subsequently received 2 more awards from late Dr. Kalam. He has more than 350 scientific research papers to his credit, and he is editor-in-chief of Journal of Clinical and Preventive Cardiology, also called Applied Echocardiography in Coronary Artery Disease. His father, late Dr. Colonel R.M. Kasliwal, was personal physician to Netaji Subhash Chandra Bose, and he was the principal of SMS Medical College, Jaipur. He was a revered physician and a teacher. The father and son wrote a book, The Impact of Netaji and INA on India's Independence. He is the current president of South Asian Society of Atherosclerosis and Thrombosis, past president of Indian Academy of Echocardiography, among others. He also established community outreach program to provide free cardiac care to community at grassroots level, which has successfully completed 2 decades. So, ladies and gentlemen, I am not a moderator. I am among the audience to listen and understand the concept of preclinical atherosclerosis. This is where we have to shift focus from secondary prevention, because that is too late in the natural history of the disease. So I welcome you, sir, Dr. Ravi Kasliwal, and it is a unique opportunity for all of us to understand his thoughts and guidance to diagnose pre-atherosclerosis and how to tame the disease early in the natural history. Once again, welcome you to the podium.
Thank you very much, sir. Thank you for those very kind words. So good afternoon, ladies and gentlemen. Dr. Rajiv, can you hear me?
Yes, I can hear you, but I wish you could be a little bit louder.
Okay, I'll do that. Yeah, thanks.
Yeah.
Thank you very much. We'll. Okay, is that better now?
Yes, it is better. It is better.
Okay. So, dear colleagues, I think the stage has been set by Dr. Rajeev Agarwal. Succinctly, he has said that just as we have pre-diabetes, we have pre-hypertension, why are we not talking of preclinical coronary atherosclerosis? It makes so much sense. And I think that's where the cue is, preclinical coronary atherosclerosis, which I and Dr. Bansal started years ago. And at that time, people used to snigger at our back that what are they doing? But then finally, it has come to the fact that we can really, with emphasis, say that, yes, this was preclinical and we nipped it in the bud. Let me start. The first part of my talk is just to say that the age, the enormity of the issue in our country. If you look at the age standardized CVD mortality in India, significantly high for men and women, 325 per 100,000, 225 per 100,000. India currently has the highest burden of ACS and STEMI in the whole world. STEMI is the common form of presentation accounting for 2/3 of all MI in India. There is no doubt CAD has increased 7-fold in urban India, 4-fold in rural India. These are statistics. And what they really mean is that more and more Indians are actually succumbing to the vagaries of coronary artery disease. And the young are not spared either. Strikingly more common in Indians, 10 to 15% of all CAD. So you can see, and the unique features of CAD in India, high mortality rates, high premature mortality, ever-increasing burden, and regional variation. All these have to be understood. Only then we realize, and because of this high premature CVD, there's obviously mortality, total CVD deaths are huge. So we can just let it pass and say, okay, when the person comes to us with chest pain, then we will start. Or we can take 2 steps backwards and say, look, this is the group we should be talking about. So how do we want to save them? So the way it started was Second World War. When it ended in the United States, the president was Harry Truman, and he got hold of a group of people and said, look, why are so many Americans dying of coronary artery heart attacks? And they defined some risk factors, and they have been very popular. So we have the risk factors for coronary artery disease, which was started years ago, and to high blood pressure, diabetes, deranged blood lipids, and smoking, a lot of other factors were also there, and they would give us the 10-year, 15-year, or 30 years mortality. But look at the South Asians. Obesity, very common. Hypertension, diabetes, atherogenic dyslipidemia, sedentary lifestyle, obstructive sleep apnea, all nicotine, these are all so common. And so we started to say, okay, can we assess the CVD risk based on these risk scores? And they were from Mayo Clinic risk score to the ACC-AHA pooled cohort equations. Dr. Manish Bansal did human work in saying that do these assess CVD risk in South Asians? Do these assess CVD risk in Indians? And to our dismay, we found that a person may be sitting with us in the evening, having a good consultation, and we may see him the next day with an acute heart attack. Because none of these have been derived for Indians, and therefore none is applicable to Indians. So we did define a Indian risk score. And to add to all this, we have now the polygenic risk score, which combines information across thousands of common genetic variants in the human genome. And now they say there is a score which is called the IRT, and this IRT is proposed to combine clinical and polygenic risk scores. Well, if you look at risk scores versus preclinical atherosclerosis, you'll come across people who have no diabetes, hypertension, non-smoking status, normal lipids, and yet they develop CAD. And of course, many diabetic, hypertensive, dyslipidemic don't develop CAD. So the relationship of risk factors with CVD is not perfect. Please understand this. This is very, very important. And this was the thing which led us to develop a schema where we can actually look at atherosclerosis. As Jennifer Robinson once said, curing atherosclerosis should be the next goal of preventive cardiology. So we started this many years ago. So the missing link between risk factors and clinically evident CVD, that's what I will focus on. But I did want to give this background so that we are all on the same page, and we are not trivializing risk factors. Those are important, but they have serious limitations. And of course, the CV, as Dr. Rajeev said about, and he's a master of lipidology, CV event reduction with LDL reduction is very well known, right from 4S study to ALL-HALT to ALERT to so many studies. This data is clear. And they said that prolonged exposure to lower LDL-C beginning early in life was associated with a substantially greater reduction in the risk of CHD than the current practice of lowering LDL-C beginning later in life. And I will come to this because this is an important Mendelian randomization analysis, but this has been modified now. And if you see, there is a linear and significant increase in the prevalence of atherosclerosis, ranging from 11% in the 60 to 75 milligram deciliter category to 64% in the 150 subgroup. But do we even look at it? Or are we just satisfied by saying, oh, his LDL cholesterol is okay, I don't think we should do anything. So what could be the potential solution? This is the cardiovascular continuum as we know today. Risk factors, endothelial dysfunction, atherosclerosis, coronary artery disease, myocardial ischemia. The fact of the matter is that between risk factors and between endothelial dysfunction and atherosclerosis, there may be a gap of a decade. As Dr. Rajeev said, it doesn't sleep, but it gives us 10 to 15 years before coronary artery disease or a stroke actually develops. So the paradigm that we thought many years ago was, can we detect disease at the stage of endothelial dysfunction or atherosclerosis? If we did that, then possibly we could not go through this cardiovascular continuum of coronary artery disease, ischemia, coronary thrombosis, myocardial infarction, arrhythmias, and so on. Have we succeeded or not is what we'll be discussing today. So this is how we were finding out disease. Acute MI patient went on the treadmill, had a ST segment depression, LAD disease. But we realized that we detected disease once the patient already had the disease. So it was just early detection of disease. That's about it. We couldn't prevent it actually, but a paradigm shift took place amongst us and various other groups who said, look, if we looked at abnormal vascular health by brachial artery flow mediated vasodilatation, pulse wave velocity, and then atherosclerosis, between these two, again, there's a difference of almost a decade sometimes. Then atherosclerosis, we can pick it up by carotid intermedial thickness or plaque formation, more important now. Coronary calcium score, which has revolutionized the way we look at coronary artery disease today. CT angiography and ankle brachial index. If we did that, then in many, many patients, we could reduce the incidence of acute MI, peripheral vascular disease, and strokes. So until the later stage of obstructive disease or plaque rupture, coronary artery disease remains clinically silent. That's what we already have discussed. On their way to developing obstructive disease or a first event, patients are not only asymptomatic, but usually have normal functional tests also. That is very important. The patient will come and tell us that, sir, you did my TMT, but after that, I had a heart attack so we have to understand the fact that there is something called preclinical. And why are we not looking at it? So atherosclerosis starts in childhood. Cellular infiltration, fatty streak, full-blown plaque rupture. We know this. This is from Ross, New England Journal of Medicine in the 70s. Classic pictures. Cellular infiltration, fatty streak formation, full-blown plaque, and plaque rupture. Somewhere here to here, we can intervene in a big way, that we can detect the time at which the plaque is forming, and so modify his lifestyle and medication, give him medication, and once the full-blown plaque is there, can we even stop it at that level? So these are important things. So from endothelial damage to fatty streak and plaque, there are several stages. And if we were savvy enough, then we could protect our patient, protect our person not becoming a patient. That basically is the main crux of the matter. So progression of early atherosclerosis, early subclinical atherosclerosis, we use subclinical and preclinical almost like synonyms. So this PISA study, which was spearheaded by nobody lesser than Dr. Valentine Fuster, who has been the editor of JACC for so long, PISA demonstrated that almost 50% of more than 4,804 asymptomatic individuals had atherosclerosis deposit. And these were considered low risk based on traditional risk factor models. That's where the whole thing is, that we have considered low risk and intermediate risk people as fine. They can go ahead and do whatever they felt like doing. But this is where we can detect atherosclerosis. So shifting gears at this point, with this background, let us start with preclinical atherosclerosis. And this diagram by Ahmed et al. Deserves attention. So we can divide it into three parts. Natural history of coronary artery disease, current practice, primary and secondary prevention, and proposed approach aimed at halting plaque progression. So if the patient is at this stage, that he has all the risk factors and we are giving him medication, it's going to do no good to him. But if we have missed this stage, where the plaque was actually forming and we have not been able to detect it, then at some point of time, he will have an ASCVD, atherosclerotic cardiovascular disease event. That is the whole crux of the matter. That can we stop a person from progressing from here to here? Because at this stage, primary prevention based solely on risk factor assessment will not work. Why will anybody just take medication without knowing why you're giving it? And as Dr. Rajeev said, secondary prevention is easy. Once the patient has had chest pain, has had an MI, has had a TIA, has had a stent implantation, then of course everybody leaps on him that, this is what you need to do. But a golden opportunity has been lost where this person may not have gone through all this. So proposed approach aimed at halting plaque progression, atherosclerosis prevention, or proposed primary prevention, plaque progression can be prevented. And you can almost say that you can prepone secondary prevention to the time of detection of subclinical atherosclerosis. That's where the crux is. So that's where the child is born, and then you start detection of subclinical atherosclerosis at a later stage. And then based on the lesion, type 1, type 2 to type 6 lesions, you can detect anything now. You can detect intracellular lipid accumulation, lipid fatty streak, small extracellular lipid pools. All these can be detected without any pain to the patient. And these are the 4 diagrams of those plaques which are seen by CTA to be at high risk. Increased outer vessel diameter to maintain luminal remodeling. This is positive remodeling. Napkin ring sign, spotty calcium, low attenuation. Just to say, this is Luke and Dawson 2022. This is to say that we can do it, that it can be done. Only we are not thinking about it. That's the main thing. So detection of preclinical atherosclerosis should be our main goal. From CIMT, we have progressed now to carotid plaques. And if you see the 3D pictures of these look amazingly good. You can look at pulse wave velocity, arterial pulse wave velocity, ankle brachial index, and of course, one of the most robust predictors is finding coronary calcium. And everybody in the world is talking now these days about coronary calcium score. So these are the three things which I will very briefly like to go through. The carotid intermedial thickness, coronary artery calcium, computed tomography, angiography. Carotid femoral atherosclerosis. This is again a picture from the PISA study, and you look at it. Distribution of preclinical atherosclerosis among those who are being followed by the Framingham Heart Score, 30-year score, and you will see that those who are at low risk had generalized or intermediate or even focal atherosclerosis already present, though we thought they were at low risk. Similarly, intermediate risk people already had this. Blue is generalized atherosclerosis, the red is intermediate atherosclerosis, and the focal is in one vascular bed. So 28% actually had 2 to 3 sites who were at moderate risk, and when we thought that they were not even at risk or at mild moderate risk. So this is the fallacy of the risk factors. These are not outdated, but they have to be seen in the real, that many of these patients, for example, the people who said they were normal and were introduced in the PISA study, almost 50%, 53% had iliofemoral arteries, had plaques. So once there is plaque, once there is subclinical disease, once there is and associated risk factors, then you know that these people are highly likely to get coronary ASCVD. That is the importance of understanding of disease apart from just the risk factors. This was our first study that we did, published in the Asian Cardiovascular Thoracic Annals in 2003. The average IMT is elevated. We found, and we did a lot of work on carotid intermedial thickness, and we also did work with the American Society of Echocardiography, rapid screening for subclinical atherosclerosis by carotid ultrasound examination. This was the HAPPY study, heart attack prevention program for you. And but lo and behold, yes, people understood that yes, carotid IMT or iliofemoral or aortic atherosclerosis is important, but more weightage was given to plaque formation. Anything in the carotids or the iliofemoral region, if it is more than 5 millimeters, you knew that already preclinical atherosclerosis was present in this patient, and he should be understood as a secondary prevention. Coronary calcium or computed tomography angiography, this is the one which will actually detect the disease, coronary artery disease. And just one study I will take, the multi-ethnic study on atherosclerosis. This had several ethnic groups and fairly large study. This is a study of 2018, 6,722 men and women. And see, the age is not all of them. Some of them were 45 to 54 as well. And after a median of 11.1 years, 500 incident CVD events took place. And see, this is how it occurred. Now look at this very carefully. Those who had coronary calcium, 0. The cumulative incidence of major coronary events was barely any. Those who had between 1 to 100 or 101 to 300, their event rate started either at about 6 months or immediately. And you can see how they progressed. But anybody who had coronary artery calcium score more than 300 was way above in the cumulative incidence of major coronary events in the percentage wise. So you can see, and this is not a new study, a lot of literature has flown down from Dr. Nasser's group, from our own group, that these things can occur despite the presence or absence of risk factor. That is the important thing, that we have to go beyond just the risk factors, but to look at. So the 10-year event rate, if the CAC was 0, was less than 1.3%, but if the CAC was 300, then it was 31% to 25% across different ages, genders, and racial subgroups. At 10 years follow-up, all participants with CAC more than 100 were estimated to have a more than 7.5% risk, regardless of demographic subset. And for each doubling of CAC, a 14% relative increment of ASCVD risk, holding all other risk factors constant. These are important data. This is important data from Dr. Budoff in the European Heart Journal. Can the CAC progress? Of course it can. CAC increases at a rate of approximately 20% per year, with almost 20% subjects with family initially 0 CAC developing CAC more than 0 within 4 to 5 years. So therefore they say that if you have a 00 CAC, 0 CAC 0 at 2 scans performed approximately 5 years apart, it gives you almost a warranty that you won't have something for the next 15 years. The rate of progression is greater in men and older individuals. Any increase in CAC over time is associated with an increased risk of MI and all-cause mortality. This, of course, is not applicable to statin-treated individuals. So you can assess vascular health and you can divide your individuals. See, these will work more on the individual level rather than a community level. High risk, intermediate risk, intermediate, low, intermediate, you can divide these. See, the main problem that always comes is when you talk of people who have intermediate risk, intermediate high, intermediate low. And if you have that in your mind, you will be able to save many, many lives. So plaque progression. So coming from formation of plaque to plaque progression in a serial CTA study in 423 patients with stable CAD, high-risk plaques with progression over time carried a 20-fold, 28-fold higher likelihood of an acute coronary event. Can you imagine how much data you have in hand if you have that kind of studies that you have done on your patients? And plaques that did not demonstrate progression in the interval between the 2 CTA studies remain free from acute events. This is huge data. Now, one word I will say about plaque-based definition. See, you have to look at an increase in the necrotic core volume with positive remodeling and the fibrous cap thinning. If the fibrous cap thins, regardless of change in lumen stenosis, the plaque has progressed. So come back to this diagram again. This is your plaque, small necrotic core and large fibrous cap. In progression, your central necrotic plaque will increase, and in stabilization, your fibrous cap will increase, and your plaque will become lesser and lesser. So that is the importance. That forget the angiography-based definition. Even if you've got a plaque, you do it after 5 years, and if you see progression, or you may see stabilization. So progression and regression, and Dr. Bansal will speak on regression, should be related to an increase or decrease in risk of rupture, as opposed to an increase or decrease in percent luminal stenosis. Many a times in a heart plaque, when we give statins, the plaque may appear to have actually increased, but that's not so. So I repeat, an increase in necrotic core volume with positive remodeling and fibrous cap thinning, regardless of change in luminal stenosis, could be considered plaque progression. And the reverse, a decrease in necrotic core volume with a resultant increase in fibrous cap thickness and calcification of the cap, even in the presence of mild increase in luminal stenosis caused by negative remodeling, could be considered plaque regression. This is important data. And we have to work very closely with our colleagues in the radiology side, because we understand better about luminal stenosis, about necrotic core volume, and about fibrous cap thickening. Acute coronary syndrome and sudden cardiac deaths are the first manifestation of atherosclerotic cardiovascular disease, signifying failure of the primary prevention strategy. No doubt about it. This highlights the fact that the notion of defining primary prevention by the absence of a historical coronary event or even functionally obstructive CAD has limited overall prognostic value compared with detection of atherosclerosis. So the way to go is subclinical, preclinical atherosclerosis. This could allow a shift from the traditional before the event primary prevention to primary prevention in subject with subclinical atherosclerosis. Subclinical atherosclerosis, therefore, can be conveniently detected by non-invasive imaging. Plaque progression is a necessary but modifiable step between subclinical atherosclerosis and plaque rupture. Plaque progression precedes cardiovascular events. So see what a unique opportunity we have, that if we have detected a plaque early on in disease, which is subclinical, this can be conveniently detected and you can change the face of the disease. So ladies and gentlemen, conclusions. Evolving strategies for the imaging of atherosclerosis suggest the feasibility of a personalized approach to atherosclerotic cardiovascular disease beyond the use of traditional risk factors. So for the first time, subclinical atherosclerosis detection offers to treat the disease rather than the likelihood of disease. And therefore, that 89 years old article by Jennifer Robinson, that curing atherosclerosis should be the next goal of preventive cardiology, seems to have come true with so much robust data from South Asia, USA, and elsewhere. So I end with these words, which Harnas Kaur Sandhu, when she was crowned Miss Universe, said in 2021, and she was talking of climate change actually. Prevent and protect is better than repent and repair. I and Dr. Bansal have just modified it a little bit. We are saying predict and protect is better than repent and repair. Thank you, Dr. Rajeev. Thank you, ladies and gentlemen.
Thank you for making it so simple as usual, Dr. Kasliwal, and making it very, very clinical. And the relevance, importance, commitment, and responsibility of clinicians to believe in pre-atherosclerosis and taming the disease when it is young, manageable, and reversible. It reminds me of a very famous quote, which is not very scientific, but very relevant and appropriate what you spoke. And I'll say that my wife is a gynecologist, and she says there is no point doing a pregnancy test in a labor room. And that aptly describes the approach, the concept that we are too late in a cath lab when the patient is lying for procedures. The most appropriate time is, this is already manifested disease, we have missed the opportunity. The most appropriate time is when it is not visible and easily manageable. So I do not know how we go about whether we invite questions and discussion now or after both the talks. How you guys?
At the end only, sir.
I think okay. At the end would be very much better. Yeah.
Okay, so now we go on to the second presentation by Dr. Manish Bansal, who is trained at a premier institutes in India in Maulana Azad, All India Institute and Ascot Heart Institute, and he was in Queensland, Australia, recipient of numerous awards and honors, a brilliant academic career. His primary interest is early detection and management of atherosclerosis, cardiovascular risk assessment, advanced echocardiography, strain imaging, speckle tracking, stress echocardiography, 3D echocardiography. He is in academics and research and published more than 200 publications, including about 80 on PubMed. He is editor-in-chief, Journal of Indian Academy of Echocardiography, former editor, Indian Heart Journal, editorial board, JACC Imaging, cardiovascular ultrasound, JI deputy editor for Journal of Clinical and Preventive Cardiology, and peer reviewer for many national and international journals. In fact, I was not even aware when I talked to Dr. Manish, I am talking to such an enlightened person and decorated person. He has been a mentor to students undergoing training in cardiology and echocardiography at Medanta, and has been invited as faculty in various national and international meetings. Atherosclerosis is a face of Janus. Those who know Greek mythology, Janus is a god who has got two faces back to back. One's face sees the current or the present, and the another face sees the future. And I think there is no better apt description for atherosclerosis. When you see the present phase of atherosclerosis, never forget about the future. Whatever you invest today, since the longevity of life has increased, returns manifold if you invest in taming atherosclerosis, even in secondary prevention. So it's a very, very important concept. Earlier, when lipid statins came, we were talking of plaque pacification. Now we talk about plaque elimination, zero LDL hypothesis. So the concept of atherosclerosis management has moved from pacification to elimination. And with these words, ladies and gentlemen, I present before you Dr. Manish Bansal, who will be taking us to the journey of pearls of secondary prevention. I invite you, Dr. Manish Bansal.
Thank you, sir. Thank you so much for the kind words. And I also thank Dr. Kasliwal for this opportunity. In fact, it is a great privilege for me to speak in front of two cardiologists who are actually the leaders and pioneers in the field of prevention in our country, where all the focus has been on intervention. And I've learned a lot from both of you, sir. So it's going to be a great honor for me. So what I'm supposed to speak about prevention and regression of atherosclerosis. Many things which I wanted to speak, Dr. Kasliwal has already covered, but I'll try to elaborate on some of those things which are relevant to our clinical practice. So Dr. Kasliwal showed us how atherosclerosis develops over the years. It starts during the childhood itself. And I'll show you an evidence from a study, the Bogalusa heart study, which included roughly 200 young persons who had died mainly because of accidents. So when they underwent autopsy, it was found that they had high prevalence of fatty streaks and plaques, even at that young age. They were 2 to 39 years of age. And with increasing age, the prevalence increased. And in those who were in 26 to 39 years of age group, the prevalence was actually 50 to 60% of fatty streaks and plaques. So this is alarming. But another very important finding from this study was that the prevalence of these plaques and fatty streaks correlated very well with the conventional cardiovascular risk factors. So more number of risk factors, greater was the prevalence of these lesions, indicating to us that atherosclerosis is not necessarily an inevitable automatic process. Rather, it occurs because of the vascular injury inflicted by various risk factors that we are well aware of. So this also means that if we take care of these risk factors, we should be able to prevent it. But at the same time, we need to understand that because this disease starts early in the life, even during childhood, we need to act early. Only when we act very early, we shall be able to prevent atherosclerosis. Otherwise, what we will be preventing is only vascular events secondary to atherosclerosis, not atherosclerosis itself. So the most impressive data to support this hypothesis comes from studies which have looked at genetic variations in lipid metabolism. So here we have data from ERIC study. ERIC study was a study which looked at various predictors of atherosclerosis in 4 communities in the USA. So in this sub-study of ERIC, the investigators looked at genetic variations in PCSK9 gene in the participants of this study. So they looked at black subjects. These black subjects tend to have 2 nonsense mutations in PCSK9 inhibitor, which were found to be present in 2.6% of this population. Now, those who had these mutations, they had LDL values which were 28% lower than the subjects who did not have these mutations. So 100 versus 138. But their event rates were 88% lower compared to the people who did not have this mutation. Similarly, in whites, there is a different type of sequence variation in PCSK9 gene, which was found in 3.2% subjects. This results in 15% lower LDL values. So they had LDL 116 as compared to the rest of the population who had 137, but their event rates were 47% lower. So in both these populations, these genetic variations caused modest LDL-C lowering, but substantial reduction in the event rates. Now, these observations are further supported by this very large study, which Dr. Kasliwal also briefly alluded to. So in this study, the investigators recruited more than 3 lakh participants, and in them looked for 9 single nucleotide polymorphisms, or as we call them SNPs, in 6 different genes related to LDL metabolism. So what they found was that for any given LDL cholesterol lowering, so let us say we take 1 millimole per liter lowering of LDL cholesterol, when this LDL lowering occurs because of genetic defect, the reduction in event rates is much greater as compared to when the same amount of LDL lowering is achieved with the help of statins in statin trials. So we know from various statin trials that if we lower LDL cholesterol by 1 millimole, we reduce events by roughly 22%. But if this much LDL lowering occurs because of genetic defect, the reduction was 54%. So in fact, if we want to achieve same degree of event reduction, we need to reduce LDL cholesterol by 3 mole per liter. 3 mole means roughly 120 milligram per deciliter. So if we reduce LDL cholesterol by that margin, only then we will be able to have that kind of event reduction, which we see from genetic defects. So what is the reason? Reason is very simple. When there is a genetic defect, LDL cholesterol levels are low right from the birth. So the atherosclerotic process is slowed down or even halted, and therefore these individuals, even with slightly lower LDL cholesterol, have much lower risk of vascular events. When we intervene late in the disease, atherosclerosis has already set in. So what we are doing is not prevention, it is palliation. And that is the reason why early intervention helps. More importantly, the investigators found that although these different SNPs affect LDL cholesterol levels to different extent, the event reduction was same if the LDL cholesterol lowering was considered constant. So for same degree of LDL cholesterol lowering, all SNPs resulted in same degree of event reduction, which means that it is not the genetic defect, it is not lifestyle, it is the amount of LDL lowering which determines how much benefit we are going to derive. And if this LDL lowering is because of genetic defect, we get much greater benefit as compared to when the LDL lowering is because of statins. So all these evidences have led to the concept of total or cumulative LDL cholesterol exposure, or LDL years, something that we talk about for smoking. So in this study, the investigators estimated that for us to develop coronary artery disease, we need to have a cumulative LDL cholesterol exposure of 150 millimole, which means that if my LDL level is 2 millimole per liter, 2 millimole is roughly 77, 78 milligram per deciliter. So with that level, I will require 75 years to reach this threshold to develop atherosclerosis. On the other hand, if my LDL cholesterol is 5 millimole, which is roughly 175 milligram per deciliter, I will need only 30 years to develop atherosclerosis, because 13 to 5 is 150. Now, this relationship is, of course, not constant. It is influenced by other risk factors. So if we have other risk factors also, the threshold is lower. So we require less LDL cholesterol exposure to develop atherosclerosis. On the other hand, female gender has a protective influence. When we intervene, we reduce LDL cholesterol level. So we shift the curve toward the right side. And now we take longer to develop atherosclerosis. So based on these observations, leading investigators like Dr. Jennifer Robinson have proposed the concept of curing atherosclerosis, and Dr. Kasliwal briefly talked about this also. So what she has proposed is that if we start very early in life and we reduce LDL substantially with whatever therapy we want to use, and then we keep doing it at regular intervals, we may prevent atherosclerosis from developing at all. So that will be like curing atherosclerosis. So that is what we need to do. Even if we don't use statins or pharmacotherapy for reducing LDL at early age, because we don't have outcome data to support those observations, and we need to look at cost effectiveness and other logistic issues also, but at least our goal should be to keep LDL cholesterol as low as possible throughout one's lifespan. So now we talked about LDL cholesterol lowering and its impact on prevention of atherosclerosis. But what about other risk factors? Other healthy lifestyle behaviors, are they also helpful? So it turns out that healthy lifestyle, as we call it, which has various components like healthy eating, regular physical activity, avoiding abdominal adiposity, avoiding smoking, moderate alcohol consumption, all these are also quite effective in reducing the risk of atherosclerotic vascular events. So here we have this study published from Sweden, which recruited more than 20,000 men, 45 to 79 years of age, free from common cardiovascular risk factors. In them, information was collected about 5 low-risk behaviors, which were healthy diet, moderate alcohol consumption, no smoking, physical activity, and no abdominal adiposity. They were followed up for 11 years. And it was found that men who had all these 5 low-risk behaviors, they had 86% lower risk of developing MI as compared to those who had 0 risk factor. And it was further estimated that if we practice all these 5 low risk factors, 79% of all myocardial infarctions could be prevented. Unfortunately, this scenario was seen in only 1% of the men, because as we know, there's so much apathy towards healthy lifestyle. We all know what is good for our health, but we don't practice it. And it was seen in this study also that only 1% of the men had all these 5 low risk factors. Now we have similar data from US also. This study published 3 years ago looked at life expectancy in relation to healthy lifestyle factors. And this study found that as the number of healthy lifestyle behaviors increase, life expectancy increases. So this is calculated after the age of 50 years. So if there is no low risk behavior, then expected lifespan after 50 years was 29. So the person is supposed to die at 79. But if all the low risk factors are present, then the life expectancy is 43 years, which means living up to 93 years, 14 years gain at the age of 50 years. Also, this study showed that the benefit of these healthy lifestyle behaviors increases when we start early and when more number of risk factors are present. So if 5 are present and started early, we get maximum benefit. And as we delay in instituting these low risk behaviors, benefit decreases. So this estimation was done after the age of 50 years. Just imagine what would happen if the same was extrapolated to earlier years. And also, when they looked at the impact of this on cardiovascular deaths, they found that presence of all 5 low risk factors was associated with 82% low risk of cardiovascular mortality. So even at 50 years of age, if we practice all these 5 low risk behaviors, we can reduce the risk of cardiovascular mortality by 82%. And lastly, I wanted to show you this study which correlates the impact of healthy lifestyle with genetic risk and other risk factors. And the study showed that healthy lifestyle is so powerful that it can override even the genetic risk for coronary artery disease. So this study was led by Dr. Amit Khera, who is from Harvard and has done pioneering work in developing polygenic risk score. So his group collected data from 3 studies: ERIC study, Women's Genome Health Study, and Melmo Diet and Cancer Study. Analyzed their data for polygenic risk score and also looked at 4 healthy lifestyle behaviors. So when they correlated this, they found that patients who were at high polygenic risk, if they had favorable lifestyle, their risk of having cardiovascular events was 52% lower. And more interestingly, patients who had low polygenic risk, which means genetically they are destined to have low risk of vascular events, if they practice unhealthy, unfavorable lifestyle, their risk of developing vascular events was much greater than people who were destined to have high genetic risk but practiced healthy or favorable lifestyle. So this shows the power of healthy lifestyle in reducing the risk of atherosclerotic vascular events. Only thing is that we have to start early and we have to sustain it for long term. And I have already talked about the impact of low LDL cholesterol levels maintained throughout the lifestyle. So this is about prevention. But what if we miss this opportunity to prevent atherosclerosis and atherosclerosis has already occurred? Can we cause regression? Can atherosclerosis be reversed? Now, traditionally, we believe that stenotic lesions do not regress. Once a patient develops critical stenosis, it will remain same or will progress with time. But that is not entirely true. So I show you an example from NEJM. This was a 42-year-old man with hyperlipidemia and a family history of CAD. He presented with a 4-month history of intermittent chest pain, underwent evaluation. CT coronary angio showed a critical stenosis in circumflex artery, proximal circumflex, and nuclear scanning showed a perfusion defect in the lateral wall. So there was a lesion which was anatomically significant, functionally significant. The patient was then put on high intensity statin therapy plus ezetimibe and was also advised aggressive lifestyle modification. Now, 4 years later, when the scans were repeated, there was hardly any stenosis in LCX and no perfusion defect. So this plaque completely regressed in this patient. Here we have another example from Japan, 69-year-old Japanese male, former smoker. He underwent a stress test. Stress test was abnormal, so CT was done. CT showed proximal LAD significant stenosis, as we can see here, but he was put on appropriate treatment, including statins. This is 1 year later, and this is 4 years later. As we can see, this stenosis has regressed significantly. And there were improvements in other measures of atherosclerosis also in this patient. So these are examples which show that even significant stenosis can regress with aggressive lifestyle management and intensive statin therapy. But this is not common. I've shown you examples which are anecdotal. More commonly in clinical practice, we find that regression occurs, but to lesser extent. But as Dr. Kasliwal mentioned, plaque size, luminal narrowing, plaque volume, these are not the only measures of plaque regression. We know that acute coronary events occur because of vulnerable plaques. So if we are able to modify plaque composition to a more favorable composition, we shall be able to reduce the risk of vascular events. So that is also a kind of regression. So regression may be in terms of plaque size. This is anatomic regression, and it may be modification of plaque morphology, which is a functional regression. Both are important. And fortunately, over the years, we have had several new imaging techniques come up which allow us to quantify plaque burden and also characterize plaque morphology, which have helped us a lot in understanding how our preventive therapies impact atherosclerosis, which has already occurred. So this image was shown by Dr. Kasliwal. This is CT coronary angiography, which is actually the most commonly used modality for this purpose, mainly because it is non-invasive. It not only can characterize and quantify total plaque burden, provides calcium score, it also shows several high-risk plaque features which indicate high possibility of causing acute coronary syndrome. And a lot of studies are now using CT coronary angiography for assessing plaque regression. This is one such study, paradigm study, which included more than 1,200 subjects. And this is one example here showing improvement in plaque composition with statin therapy. Now, apart from CT, we have several invasive imaging techniques like IVUS. IVUS is considered to be the gold standard for quantifying plaque volume and burden invasively. So in this study, as we can see, there is reduction in plaque size and there is negative remodeling with statin therapy uh, over a period of 8 to 12 months follow-up. This is a modification of IVUS called virtual histology IVUS. So here, not only we are able to quantify total plaque burden, we can also characterize plaque composition. We can quantify how much of the plaque is fibrous, fibrofatty, what is the necrotic core volume, and whether there is calcium or not. And in this example, as we can see, there is this is a control group. We see increase in unfavorable morphology with time. On the other hand, in patients with statins, there was improvement in the plaque composition. Then very recently, we have had OCT coming up. OCT is an excellent modality with very high spatial resolution, but unfortunately, its penetration is poor. So it is used mainly for seeing the inner side of the plaque, the luminal side of the plaque. So we can look at fibrous cap and characteristics of cap. So in this example, as we can see, there is significant increase in the thickening of fibrous cap over a period of 13 months with statin therapy, high dose statin therapy. So once a fibrous cap thickens, this plaque becomes stable. This plaque is not going to cause acute coronary event. And lastly, we have near infrared spectroscopy, which is a modality for looking at amount of lipid in the plaque. So here we have an example. This patient had LAD stenosis. As we can see, there's a lot of lipid here. 1 month later, anatomic stenosis remains same, but all the lipid has gone. So this means that this plaque has become stable, unlikely or less likely to cause acute coronary event. So using all these modalities, a number of trials have been conducted over the years, looking at the impact of various therapeutic interventions on atherosclerosis. So we have trials with statin compared with controls, high intensity versus low intensity statin therapy, SDMI, PCSK9 inhibitor, other therapies like CETP inhibitor, and lifestyle factors also like exercise and diet changes. All these have been studied, and in general, what has been found is that lower the LDL level achieved, greater is reduction in the plaque volume, except in the recent PCSK9 trials, which have not shown that kind of plaque regression with the kind of LDL reduction that was achieved. This is a matter of further investigation why this has been happening so, because even the event rates have also not shown that much reduction with PCSK9 inhibitors as we would expect from the amount of LDL lowering that these agents cause. But nonetheless, what all these trials show that aggressive lipid lowering can cause plaque regression, and statins appear to be the most effective options for this. A number of trials have compared this and have shown that plaque regression with statin has a dose response relationship. More intense treatment, greater is plaque regression. And here we have this famous Sachin trial, which compared 80 milligram atorvastatin with rosuvastatin 40. So these are generally considered equivalent, but data shows that rosuvastatin 3 times more potent than atorvastatin. So effectively, rosuvastatin 40 is more potent than atorvastatin 80. And this is exactly what was seen in this study also. We had much greater reduction in LDL cholesterol with rosuvastatin, much greater rise in HDL cholesterol, and there was much greater reduction in plaque size and more number of patients developing plaque regression with statin therapy. Nearly 2/3 of all patients had plaque regression. And lastly, this is a meta-analysis comparing various studies, looking at various studies that compared rosuvastatin and atorvastatin in a ratio of 1:2, which have generally shown that rosuvastatin in half dose produces more intense plaque regression as compared to atorvastatin. This is mainly because of their differences in the impact on LDL cholesterol. It is not a molecule specific, but related to their LDL lowering effect. So to summarize, maintaining low LDL cholesterol throughout one's lifespan is one of the most effective ways to prevent atherosclerosis. Healthy lifestyle is also helpful, and earlier we start, better it is. Once established, atherosclerosis may be regressed to a variable extent. Both reduction in plaque size and plaque stabilization mean regression, and they are clinically relevant. Lipid lowering therapy, especially statins, are the most useful for this purpose. Thank you so much.
Thank you, Dr. Manish, for conceptual to clinical topic where you have shown that atherosclerosis regression is a reality. Even if we started with plaque pacification, regression, and we have added third dimension that even the atheroma characteristics can be changed and they become stable, less notorious for ACS, and people can continue to have good life. And that is what all the trials have shown, from Courage to Ischemia trial, that acute coronary syndrome is a different ballgame altogether, but chronic stable angina is a different disease. They are not the same disease. They are two sides of the coin of atherosclerosis, but manifest very, very differently. So, Dr. Kasliwal, what is your take on it? How do you see that, how we infuse that confidence and desire in clinical cardiologist, intervention cardiologist, that they have to move away from mechanical cleaning to metabolic cleaning, because that is a very, very big challenge. And this kind of such hard data is not translated, I'm sorry to say, by intervention cardiologists, because they have the highest risk patient and still they are being deprived of the best proven treatment. I seek your comments.
No, I'm absolutely with you. You know, I would actually even go away with using the word primary prevention. You know, I would say that if I have found the risk factors and atherosclerosis in coronary artery disease, I would say let us start secondary prevention for this patient. That is the first thing I would do. Secondly, I would like to tell cardiologists that there is not too much radiation involved in this, and they have to distinguish between population studies and precision medicine. They're two different things, two different ballgames. Yes, as the country goes forward, economy improves, maybe there will be a situation where we will be at least be able to do iliofemoral atherosclerosis can be done easily. And of course, a calcium score. So the mindset, as you said, from catheter cleaning to metabolic cleaning has to come from the medical school level, from the post-graduation level. That is very important. I and Dr. Bansal have seen that our best DNB students are with us very happily. When the results are out, they bid goodbye and actually join the cath lab somewhere. Nothing wrong in it. But however, you do need a whole pool of enthusiastic people who can sit across and talk to people. Here, there's a lot of talking involved. And on the other hand, say that, look, we can actually stop it. We have already started secondary prevention in you. And Dr. Bansal has pointed out very beautifully that we are not just talking of drugs. Life Simple 7 is actually Simple 7, but only 1% people followed it. What a tragedy. In a highly educated community, in a highly educated country where the mass of people is much less than in our country. So, Dr. Rajeev, there are multiplicity of issues, but I don't think it is undoable, or it is not something that in the 21st century, with so much internet data space available to us, we can't get hold of professors all around the country and say, look, this is what you got to teach. That's not my take. It has to be a whole. After all, when we were doing DM, there was no angioplasty or this thing. Then we did change, no? So we have to rechange ourselves now. But I ask you one question. Do you believe that the term primary prevention is almost outdated?
I think this is a very good question. Manish, you want to say something, please?
Yes, sir. The question that you asked regarding the inertia in using statin, actually, every day I come across a few patients, young hypertensives, who are taking aspirin, but no statin. And it is so frustrating to see those prescriptions that we are treating patients with a drug which is known to be harmful in them, where there's no indication, and we are completely denying them a drug which is going to save them from having vascular event. It's all because of so many myths and lack of knowledge, and also lack of effort on the part of clinicians to convince the patients that statin will benefit them, will not cause harm. We don't put in that much effort, so patients are also reluctant, they stop taking it, and many times clinicians don't even prescribe statin. And after intervention, so many patients roaming around with LDL values of 80, 90, 100, 110. That is absolutely unacceptable.
Correct.
I think this has to move forward, and Dr. Kasliwal said that we have to change young minds. And Dr. Braunwald said that the 21st century is a century of diabetocardiology. I am aware that in Holland, there is a separate specialty called diabetic vascular disease, diploma in diabetic vascular disease. I personally feel and call upon why we can't create a concept of metabolic intervention cardiologist, because recently I was in a case presentation debate, let me say, with Praveen Chandra, and they talked about a patient who has got a lesion within 9 months of treatment of first angioplasty, and the patient has come in 9 months with repeat lesion in LAD, and the LDL maintained during 9 months was 112. So this is the problem. This is the problem we are facing, that there is inertia versus ignorance that has to be challenged. And clinician, I do not know, I feel emotionally upset that the patient is coming so fast after intervention. It should embrace the intervention cardiologist, and they should feel that metabolic management is the way forward, and it is doing an angioplasty is a patchwork, making disease zero, resetting the clock. If you look, ask me what is the best word for angioplasty, I'll say you have reset the clock of atherosclerosis, but it will start ticking again. So don't forget that disease is going to come back again. And if you don't have that concept, I don't think you are intelligent angioplaster, or you have been groomed in proper cardiology. So that is how I look at it. And it is no belittling. It is not shame.
Yeah.
When you look after, I think lipidology is the simplest branch. Like there are many drugs for hypertension, many drugs for diabetes, but we have very few drugs, and management or titration of LDL is very, very simple. It is almost harmless.
Yeah.
And when we should not confuse that high dose statin is similar to high intensity lipid lowering therapy. They are two different things, and we should try to bring in newer molecules. Like simplest thing, we are fortunate we have ezetimibe and statin, over the counter and out of patent, and that should take care of large number of patients. And we should, I even ask the industry people that discontinue acosprin and atorvastatin 10 milligram molecule, because you are harming community, giving a molecule to the clinician, and they practice with this kind of whole lot of diabetologists. Dr. Kasliwal, I don't want to play that I am a smart guy, but I see endocrinologists from even Medanta, they are putting patients on acosprin AV. And what Manish said, that these patients don't need aspirin, they need high intensity statin, and they are oblivious of this fact, and they're not able to unlearn. That is the biggest challenge, what you said, they are unable to unlearn and relearn. So this is a very big dilemma, that such a proven thing, such a lot of evidence, and we are still lacking. So I invite both of you further, that what are the innovative ways we can translate that into medical community? What can be the another innovative ways?
Rajeev, before we come to that, another aspect is that Dr. Manish Bansal writes a perfect prescription of 40 milligrams of rosuvastatin after an angioplasty. And when the patient comes to him in 3 months, it's been reduced to 10 milligrams by the local guy, because he said, "Yaar, kya kar rahe ho aap? Ye to aapko muscle." And these so-called side effects of statins have been so, to use a wrong term, overhyped. And there was a study recently published in JACC that when these guys were given placebos, they again had the same symptoms. So the only way I look at it is at the DNB training program, is at the MD level actually. But you see physicians giving, let's say, chlorothiazide and telmisartan combinations for years together. How can you do that? So I think it's a whole new change. Writing drugs has become like a very commonplace kind of a thing, and not in adequate doses. So you have to.
Sir, I'll seek your. Manish, you want to say something?
No, sir, I'm just thinking what could be the ways to overcome this challenge.
Yes. Sir, I want to seek your opinion and guidance regarding diabetes and pre-diabetes. The tool is very simple, blood sugar, HbA1c.
Yes.
How we create something which can diagnose pre-atherosclerosis clinically or by simple tools, because the biggest challenge is I understand the concept of pre-atherosclerosis, but I find it difficult to practice on community basis. I can practice it on individual basis. So there is a missing link where we can create some kind of community tool which can pick up atherosclerosis. I believe that will be the golden era or golden time, because right now, pre-atherosclerosis is very difficult to practice on the community basis. So what are your thoughts on that program?
No, we did a study in Haryana itself, looking at carotid intima-medial thickness with Dr. Valentine Fuster and others. And he came to the conclusion that, you guys have done a great job, because in many of these communities, people can't even get a lipid profile done. So you have actually taken it to that level. But I feel that this is possible. I mean, of course, not carotid as carotid plaque, and actually iliofemoral is supposed to be very, very positive. It's a good method. But again, the question comes to education. People have to believe in atherosclerosis imaging. People have to first believe that if you decode atherosclerosis, you're actually helping this patient, not becoming a patient. So that is the important thing. And powerful data from Manish that in many of these patients, even if they do not like medication, if they follow Life's Simple 7, even that could be of a great help. So we will have to combine the good things with the basic investigations. And of course, a lipid profile has to be done. I mean, there is an article just in coming issue of JACC in which they have said LP(a) correlates directly with calcium, with coronary calcium. Direct correlation. But we are not even going to that stage. We are still going to the stage of just looking at atherosclerosis by a simple transducer, non-invasive pregnant women, no problem. And LDL cholesterol.
Sir, there is a question by Dr. Geeta in the chat box. So I ask both of you to answer. Calcium score as a preventive tool in combination with the disease, with statin for disease modification. What is the score? So calcium score as a preventive tool. There is a question by Dr. Geeta.
This is no longer a question. Calcium score is the tool. And me and Dr. Bansal, we just finished an article on Dr. Manish, what was it, 380 patients?
Yes, sir.
So let Dr. Manish talk about it. He'll tell you.
See, actually, all three of us wrote that editorial also for Indian Heart Journal, Holy Grail of Atherosclerosis Imaging, where we discussed about the value of calcium score. So calcium score, among all the measures of atherosclerosis, subclinical atherosclerosis, calcium score is the most robust. If calcium score is 0, then the 5 to 10 year risk of events is very low. If it is above 100, then 10-year risk of events is high. We have a lot of clarity about that. And this relationship is largely independent of risk factors. But if we have to use calcium score for day-to-day clinical practice, I would suggest that we use it. See, first is that statin therapy is the cost benefit ratio is so favorable. Then in most patients, we can prescribe statin even without any imaging. But in patients who are reluctant to start statin therapy, and if you want to convince them, we can use calcium score to demonstrate that, look, you are developing atherosclerosis, you must take it. Or in elderly patients who've not been on statin so far, or who've been on statin so far but appear to be low risk, there we can use calcium score to withdraw the statin therapy. So these are the two situations where I would use it. But for a larger population, we don't need to use statin therapy for calcium score for deciding about statin therapy. If we want to decide about aspirin, if we want to decide about the possibility of obstructive CAD, in those situations, calcium score is a good initial tool.
Dr. Rajeev,
Yes, sir.
There'll be a lot of questions and answers, but all of us have to just get on with our clinical work. But
yeah, there is a last question. I think this is very important by Dr. Jagdeep, if I am reading right. How frequent we should repeat lipid profile? Is empty stomach lipid profile mandatory? How frequently we should repeat lipid profile, and is fasting mandatory?
So I repeat lipid profile first time after 6 weeks of initiating therapy to make sure that we have achieved sufficient LDL lowering, and if not, then I intensify treatment. In some individuals, I start with very intensive treatment right from the beginning. Those who are at high risk, in them we don't need to check LDL lipid profile after 6 weeks unless baseline LDL was very high. After that, although the guidelines say that if you're using high intensity therapy, you don't need to repeatedly test it at regular intervals, but I don't think that that is correct. At least 6 months to 1 year, we should be repeating it just to ensure that the patient has been compliant and there are no other patient related risk factors which have altered the efficacy of lipid lowering therapy. So for 6 weeks and then at least 6 months to 1 year, I repeat. And fasting lipid profile is not mandatory unless triglyceride is more than 400. It does not influence LDL cholesterol level that much. So for all practical purposes, we can do lipid profile even in fed state. Not doing lipid profile just because the patient is not fasting is going to cause more harm.
Correct. I agree
Thank
with
you
that.
very much. I think we had a good discussion. Just before closing, I'll request Dr. Kasliwal. There is a request from Dr. Ajay Sinha, and I think that's a good point of discussion, that what is beyond LDL lowering. So maybe any time in future you create another Zoom webinar on what is beyond LDL, and the person wants to know about inflammation. So this is a good food for thought.
Yes,
what is beyond
yes.
LDL? So once again, I thank Dr. Kasliwal, Dr. Manish Bansal for creating such a wonderful platform for discussion about atherosclerosis, how it is to be handled, and how to tame the disease. And don't miss the unique opportunity to tame atherosclerosis. Thank you very much.
Thank you very much.
And once again, I thank the audience for joining us in the afternoon. Thank you very much.
Thank you.
Thank you so much.
Thank you.
Thank you.